Starting. Good morning, everyone, dear colleagues and friends. Greeting from Campinas, Brazil. We hope you are all safe and well. This is uh, uh, another ICS live event. I'm Cássio Riceto from the Department of Urology of the University of Campinas, São Paulo, Brazil, and I'm going to chair this live session. The subject today is how to evaluate the extension and involvement of the male urethral stricture. We welcome you to join the discussion and ask the faculty questions through the comments functionality in Zoom, in YouTube, which you'll find next the About session on the page you are watching now. You can leave your questions now, and we will have questions after each talk. If you are watching this back, not live, you can still leave your questions to the faculty, and they will be picked up by them. Then I'd like to introduce our speakers today. We have a huge team, starting with Professor Carlos D'Ancona, who is full professor of urology and coordinator of the Division of Functional Urology at the University of Campinas, Brazil. Dr. Nish Chinkunchevam, who is the lead consultant reconstructive urological surgeon at Cambridge University Hospitals and one of the largest biomedical campuses in Europe, who treats patients with bladder dysfunction, incontinence, reconstruction, and the urethral stricture disease. He was also secretary of Female Neurological and Neurodynamic Section of British Association of Urology and invited member of the European Association of Urology Sessions of Female and Functional Urology and Young Academic Urologists. We also have with us Professor Daniel Lahan, who is Assistant of Radiology Department of University of Campinas, Brazil, our colleague from here, and Professor Athanasi Bilic, who is full professor of pathology at our University of School of Medical Sciences of State University of Campinas also, and probably the most relevant specialist in uropathology in Brazil. Okay, let's move to our agenda. First, Professor D'Ancona will deliver his lecture about times of new technologies. Is ureterocystography still alive? Then Professor Nitis will present the theme about ultrasound imaging for urethral stricture disease. After that, we have Professor Lahan presenting what MRI can add to the decision-making process in urethral stricture. And further, Professor Athanasi will present anatomic and pathological aspects of urethral stenosis. After each presentation, we reserve some time for the audience questions. And at the end, we have a discussion about some practical clinical case. So I invite Professor D'Ancona for your presentation.
Good morning. Thank you, Professor Cássio, for the introduction. I will share my slide. You see my presentation? Okay. In times of new technologies, ureterosystography is still alive. I have no disclosure of this lecture. My answer is yes, and I will try to convince you why. Disorder of male urethra can be difficult diagnosis entities. The clinical history or symptoms can be non-specific, and the physical exam is often limited. Ureterosystography plays a crucial role in the diagnosis, treatment planning, and follow-up of wide variety of male urethral disease. Retrograde ureterocystography is injector contrast retrograde into urethra. And you will use a small Foley catheter, 12 to 14 French, is placed in the fossa navicularis and fill it to 1 to 2 ml to avoid leakage of the contrast. Or we can use a Broadley clamp. Following that, we perform avoiding cysturetography. The bladder is filled to 200 or 400 ml. And during voiding, we take picture under posterior and oblique film. A quick review of anatomy. We can divide urethra in posterior and anterior urethra, and the division is made by urogenital diaphragm. Posterior urethra is component of prostated and membranous urethra, and penile urethra, bulbar urethra is anterior urethra, and the division and penile scrotal angle. In this image, we observe a retrograde urethroplasty with many stricture of the penile urethra. In the same patient, during void histography, we observe dilatation of posterior urethra until the stricture in the bulbar and penile urethra. Very interesting paper made by Pomitieri, who reviews the characteristic of urethral stricture in developed world. They find that the most local stricture in the urethra are the bulbar urethra followed by penile. And the age of the disease, about 20 to 40 years is more frequent age of occurrence. But also important is the etiology. Most of cases unknown, but many cases provoked by catheterization or transurethral resection. So we play a big role in this disease. So we can improve and decrease the rate of urethral stricture with our knowledge and careful on these procedures. But also I take another article from India, and this article is about urethroplasty. But I just select a characteristic of the population in this study. And also, they found the penile urethra as the most location of stricture, and the post-instrumentation is the most common cause of urethral stricture. The indication of this exam in obstructive symptoms, in acute urinary retention with difficult to insert in the catheter, in penile or urethra penetrating trauma, and also after traumatic and gross hematuria. What information this study provides? In this study, we evaluate anterior and posterior urethra, evaluate urethral injury, neoplasm, fistula, and evaluation urethral stricture, location, and length. In this article is a pictorial review of urethral imaging, and I select a classification of posterior urethral trauma made by Calapinto and Nakola. Interesting, they divide in three types. In pelvic trauma, when we have a rupture of puboprostatic ligaments, we observe elongation of posterior urethra without extravasation or contrast. Type 2, rupture of membranous urethra and extravasation of contrast in retroperitoneum. And type 3, we have extravasation contrast in retroperitoneum and perineum, and rupture of membranous and bulbar urethra. What is the pros of this study? It's familiar for the most of urologists, evaluate anterior posterior urethra, provide additional information about concomitant bladder disease and vesico-urethral reflux, and it's a low cost. The cons, it's ionizing radiation, position dependent, no soft tissue details, and may underestimate stricture length. In this image, we observe vesico-urethral reflux, diverticulum of the bladder, and dilatation of posterior urethra. In this other image, we observe the bladder is over the posterior urethra. What's happened? Probably the X-beam is in wrong angle position because this angle have distortion of the image. Also, if you perform a very high pressure to inject contrast, we promote rupture of the mucosa or urethra, and stravasation in the corpus spongosa and veins. And it's impossible to identify where is the stricture, where is the length of the stricture. These are some limitations of this test. In conclusion, X-ray is available in all centers, and this test is easy to perform, low cost, easy interpretation, and remains as a gold standard. Retrograde urethroplasty is old exam, but is still alive. Thank you very much.
Okay, thank you, Professor Carlos. I'd like to start with a question for you. Nowadays, in which situations are acceptable for reconstructive surgery to propose reconstruction of the urethra based only in uretrocystography, in your opinion? Any group of patients is based on the stent of the urethral structure? What do you mean?
Well, I believe it's more important in this study, you do the diagnosis. If you have possibility to use other techniques, you can improve your information of the case. In my opinion, in the posterior rectal trauma, you do a diagnosis during the trauma, but to perform a surgery, maybe other exams can help to confirm the length of stricture. Also, I say before, this type of exam don't show the soft tissue compromise. So I believe the uretroscopy is the best study to start evaluation of the patient. And in some cases, you can do only is enough, but if you many cases, you need more other exams to help you your decision and choose your technique. Let's also listen as other friends what they think.
Okay, so in your practice, you use the retrocystography as a screening test, and in most of time complement the information with other examinations. Okay?
Correct. Also, we perform during the procedure always endoscopy or cystoscopy.
Okay, and another question. Sometimes we receive patients that already has a cystostomy, more complex urethral stenosis or post-health trauma. So, in your opinion, we in the past we used to use the combined antegrade and post and retrograde retrocystography to assess this kind of patients. What's your opinion in the role of this exam in our modern practice?
Well, many patients cannot avoid if you have a complex stricture, if you fill the bladder in cystostomy. So in this case, we prefer use antegrade flexible cystoscopy. If you don't have a flexible cystoscopy, you can use Benike, but be careful, we can perforate the bladder. So at our hospital, we use always flexible cystoscopy.
Mm-hmm. Yes, flexible cystoscopy is really better. And sometimes Benike cannot touch exactly the distal point of the urethra. So it's an exam that we used in the past. So, but nowadays I don't know if it can play any role in this assessment. Now I invite Professor Nitish to give your lecture. Please, Professor.
Thank you very much. Good morning, everyone, and good morning, ICS and my colleagues and Professor Cassio. Thank you very much for your introduction. Can you all see my presentation? Great, thank you. So my name is Nikesh Thiruchelvam. I'm a urological surgeon in Cambridge. We've grown to a very big site. We started out a few hundred years ago as this small little hospital there on the upper left, and we've grown to this very large, very large biomedical campus. I'm going to be talking to you about ultrasound imaging for urethral stricture disease, which we concentrate on a lot in Cambridge and have popularized the technique over the past few decades. I have no disclosures related to this specific presentation. So I'm going to talk to you about the evolution of the technique and how it developed. And then I want to show you some very good videos, which I think highlight the advantage of using ultrasound for examining urethral stricture disease. The very first early descriptions in the literature were in 1988. And these examiners realized that two-dimensional urethropography could be very variable in the pictures that you got. And it depended, as Professor Carlos showed there very well, it depends on the stretch of the penis and the position of the patient and how you get those images. They postulated the advantage, of course, with ultrasound was there is no radiation. And also you can get a three-dimensional view on what is going on. And most importantly, the degree of spongiofibrosis and the degree of occlusion. So the first paper by well-known urologist Jack McNanich, who's very well-versed in urethral stricture disease and trauma of the urinary tract. And he postulated three types of stricture visible on ultrasound. They used a transducer applied to the dorsal surface of the penis, and they applied some slight pressure and stretch of the urethra, thereby minimizing the near-field artifact. They were able to evaluate the entire anterior urethra. And in fact, they did this study, and you'll see in the subsequent papers, most of these papers had standard retrograde urethropography first and then the ultrasound, because this was a technique in evolution. They described three types of stricture, mild, moderate, and severe, and it's primarily related to how open the lumen of the urethra is, but most importantly also the degree of spongiofibrosis, which you cannot see on a retrograde urethrogram. You'll have to excuse that these pictures are a bit fuzzy, but you have to remember these were taken over 30 years ago. But in these pictures in their paper, they clearly describe the stricture with the standard urethropography, and then you can see them, albeit I appreciate grainy, on these ultrasound images here. But if you, hopefully you can see my arrow moving, there's the stricture there, there's the stricture there with closure of the lumen. So they did distend the urethra with saline. They suggested that you avoid transducer pressure to prevent urethral compression as you press with your transducer. And also, specifically for this paper, they took biopsies at the time of urethroplasty, and they postulated that the degree of spongiofibrosis they found in histology was the same as it was on ultrasound. There was a further American paper in 22 patients around this time. They had the patients in the supine position with the pelvis supported on two folded towels, and they asked the patient to void, which I appreciate, I think is difficult for men and women to lie flat and void. If they got a full continuous flow, they then applied a clamp at the end of the corona to distend the urethra with urine. They scanned dorsally on the penis to image the pendulous urethra up to the level of the suspensory ligament of the penis. And to look at the distal bulbar urethra, they performed ultrasounds transscrotally and also transperineally. If they saw any irregularity, or if they couldn't obtain a full void while lying flat, they then did a retrograde injection of lignocaine jelly to distend the urethra. And again, they got very good pictures. Again, you have to remember the time of ultrasound was not so developed in those days. But as you can see, especially in this bottom picture, possible saculations and stricture disease on urethropography on the right, and very clearly demonstrated on the ultrasound on the left there. Also in the same year, from Germany, a technique was described by placing saline retrograde injection and then a penile clamp, ultrasound placed ventrally in this case, to look at the urethra. And they described excellent correlation with the urethrogram. The same authors then took it a step further and said, actually, if you can see this degree of spongiofibrosis on ultrasound, which you cannot see on urethrography, can you use that to plan your operation, predict your next step? So what they did was they showed strictures, and then they examined them to see if there was recurrence. And they postulated, would it be possible to predict which patients would have stricture recurrence at the primary location after internal urethrotomy? They had a slightly unusual technique in that they did deep incisions for their urethrotomy at 12, 4, and 8 o'clock, and then injected cortisone jelly, steroid jelly, and then left a catheter for 24 hours. But in fact, their results were quite impressive. They suggested that if you had group A, quite a lot of periurethral scarring, you had a high chance of recurrence of stricture disease, 84%. And if you had no scarring on ultrasound, your chance of recurrence was very low. In their small numbers, it was 97% were stricture-free at follow-up. So a very interesting study to suggest that using imaging may alter your decision-making and your counseling with patients with urethral stricture disease. This was a paper from India a few years later. They also really just described the technique. They did a retrograde studies and then filled the urethra with saline in 28 patients. And they accurately predicted the stricture length, the retrograde urethropathy underestimating the length in most cases. And ultrasound also picked up additional structures and problems, periurethral structures, including the urethral wall, corpus spongiosum, the cavernosa, the bulb, and the external sphincter was visible. And they suggested that they saw, again, grading of periurethral fibrosis, depending on the depth of involvement of the corpus spongiosum. Around that time in Germany, they also compared retrograde urethropathy with ultrasound, with retrograde saline injection, but also urethroskopy. So if you take flexible urethroskopy as 100% positive for picking up the stricture, 100%, they found that urethral ultrasound was very good at correlating with what urethroskopy saw compared to retrograde studies, which were only 87% accurate. So they missed stricture disease on retrograde ureterogram that were visible on flexible cystoscopy and were nearly always visible on ultrasound scan. Back to the States, this paper in 95, very similar, did 100 patients with strictures. They all had retrograde urethropathy and then saline injection for ultrasound, and they found very good correlation and very good identification of strictures and its length and caliber and amount of periurethral scar tissue on ultrasound scan. And then there's a series of papers from my unit in Cambridge. This was before my time. I was still a medical student in 1994. But Philip Bearcroft and Lowell Berman, recently retired, described after urethrogram using an ultrasound again with the Foley catheter in situ at the end of the urethra to distend with the radiographic contrast medium. They used longitudinal urethral studies using a 7.5 megahertz transducer on the ventral surface of the penis with the penis extended along the abdomen, much like the picture I showed you earlier from the German paper. And then again, transscrotal and transperineal imaging for bulbar urethra, more the anterior urethra. They thought actually that the balloon of the Foley catheter hindered visibility of the distal urethra. So they trimmed back the balloon. So just an early description paper here. They did it in 11, just a handful of patients, but they found very good correlation with the contrast urethrogram compared to ultrasound. You can see the ultrasound imaging there showing the very nice imaging of the stricture disease. And they also first started talking about periurethral cuffing and periurethral scar formation. They then took this the next step and said, rather than putting a catheter in, see if they can get the patient to void. So they asked the patient to void, and then midstream, the patient would pinch the end of the penis to then distend the urethral lumen and the urethra. And they could then demonstrate very good images of the distal urethra, which you cannot get with a urethrogram. And they were able to detect strictures in the distal urethra that were obscured by the catheter balloon if you were doing a retrograde urethrogram. And they found a very successful technique for demonstrating these filling defects and also periurethral soft tissue thickening. And here's, again, ultrasound is starting to get better now. The pictures are starting to get clearer. And you can see clear images. And here are some images in their description where actually in the bottom there, the urethrogram looks pretty normal on the left and in the center. But actually, if you look on the ultrasound, you can pick up abnormalities within the urethral wall. This was a paper by Alan Murray, well known in Texas and the States, who publishes a lot on urethral stricture disease. And they described a technique where they filled the urethra with saline and with a catheter, and then carried on taking pseudo-antegrade studies of the urethra, trying to examine the bulbar urethra. They were concerned that the urethra and the bulbar urethra was abnormally foreshortened when you did a retrograde urethrogram, but you cannot take the angle appropriately because the bones are in the way, the pelvic bones. So they described using the ultrasound in the perineum to try and get very good images of the anterior urethra. The concern was that these end-on views of the bulbar strictures on radiography were reducing their apparent length, and the urethra was actually longer and the stricture disease was longer than seen. And again, although they found it difficult to accurately reflect the periurethral fibrosis in the bulbar urethra, the ultrasound showed very good spongiofibrosis, and it was very good at showing lumen that could not distend beyond 3 millimeters, suggesting there was lots of dense collagen deposition. And these strictures would be better treated by excision and anastomosis or grafting rather than a urethrotomy. And this showed this image very nicely of the bulbar urethra, showing a very good stricture disease there. And this was a further publication from our unit where, again, patients were pinching the end of the urethra as they voided. They found that this was possible in 90% of the patients, including very young children. And they showed very good anatomical descriptions of distal urethral stricture disease. You can see a nice reconstructed image from ultrasound on the bottom there. And you can see with the white arrow that the narrowing of the distal urethra. The star there is the bulbar urethra and the P is the prostatic urethra. And they had, I won't go into them in detail, they had 2 more papers, again, describing techniques. These are all urologists that work, radiologists that work in our department. Finally, there was a more recent paper just last year that used SonoView to show the male urethra. I didn't think this particular paper showed any additional information apart from showing some colorful pictures, which may help people learning the technique to show abnormalities within the disease. I'm going to try and show you some pictures now, some live video recordings. Can you let me know if you can see that, please? Great. So here you can see a live video. This is someone voiding. So this is the length of the penis. This is the urethra with the arrow. And this pattern here is the actual urine coming out. And you can see here, this distal disease is very scarred. And you would not be able to see that. And sometimes you wouldn't be able to get your catheter in if you're doing a retrograde study. This is another one. You can see even longer abnormal scar tissue coming along here, quite long. So that one would definitely be not just a simple meatoplasty, but that would be a 2-stage buccal mucosa graft urethroplasty. This is someone that's previously had a reconstruction as a child. You can see the foreskin still there, nicely present, the prepuce. This is the corona. And again, you can see this is very abnormal because they've had repair as a child, often with preputial skin or scrotal skin, and it's very scarred. So again, with this case, you would excise all this tissue and then place more graft to reconstruct the distal urethra. And then I've got one final video to show you. And again, very similar. In this picture here, you can see how incredibly tight and narrow the lumen is. So this patient would have struggled quite markedly with symptoms because there's a very narrow distal urethra there. It would be sub 1 millimeter. So very narrow and very symptomatic. So in summary, can you see my PowerPoint screen there? Thank you. Thank you. So in summary, I think ultrasound of the urethra is a very good technique. We use it regularly in our practice in Cambridge. It produces, as you can see from those videos, very high quality imaging of what is going on in the urethra. It gives you very accurate measurements of the length of the stricture, but also importantly, the amount of spongiofibrosis and scar formation. It does not underestimate the stricture length. There is no uncomfortable catheter for the patient. There is no uncomfortable retrograde flow because we get the patients to void. Perhaps, and there are inadequate studies in this, but perhaps ultrasound could be used to actually infer which strictures should be operated on by which surgical technique and may predict the recurrence risk after ureterotomy. And of course, there's no radiation involved, especially important in young children where the testes are close by. There are, of course, some disadvantages. It's very much an experienced technique. You have to be experienced in ultrasound, experienced in being able to obtain good images, know how to twiddle the knobs on the ultrasound machine, and also be able to converse with the patient and describe what you need them to do. So it is user dependent. We don't typically use it for the bulbar urethra. I think the images are difficult there, and certainly you cannot use it for posterior urethral distraction defects following pelvic trauma, because you just do not get good views of the bladder neck area. And of course, you need patient cooperation, but our studies would suggest as long as the patient is forewarned, they will have no problem performing this test. Thank you very much.
Thank you, Professor, for a nice presentation, beautiful movies. I'd like to ask you if in the assessment of female pelvic floor and in proctology, the assessment advanced a lot in using 3D ultrasound for evaluation. We can make a volume and reconstructions and so on. So I'd like to ask you if it's also possible in urethral assessment, okay, to use 3D ultrasound.
So I'm not an expert ultrasonographer or radiologist, so I think the images that have been developed and the images I've seen are very good. I'm not sure the additional value that you get over the images that I've shown you today. We are doing a study. We've collected over 150 patients now using perineal ultrasound to look at the male pelvic floor before and after radical prostatectomy. And that shows very good imaging of the male pelvis and the sphincter. But the difficulty is actually for our radiologists is learning the technique. There are no real adequate papers or descriptions or in their training of how to do this technique. So it's a matter of learning as they were going along what they were seeing.
Yeah, I think this is the one of the major problems. Is not how can I say routine for this kind of evaluation among urologists. So it's based only in the experience. So it's hard to transpose the results from neurologist to the other one. No? I'd like to ask you if it's possible to, it's is it a role for the intraoperative ultrasound during a urethral reconstruction to establish exactly the point of spongiofibrosis, to cut, to make the reconstruction better? What do you think?
That's a good question. We haven't done that. And I think primarily we use the ultrasound to predict and inform me and the patient the length of the stricture, to try and predict whether it's likely I will need buccal mucosal graft, which also helps organize theatre operating time and knowing if it's going to be a 2-hour case or a 3.5-hour case. The intraoperatively, I think it's quite easy to see the extent of spongiofibrosis. It's easy to see the healthy urethral mucosa to the unhealthy urethral mucosa. So cutting back to healthy urethral mucosa with your scalpel, scissors, I think is straightforward. You know you're in healthy tissue. By surgical experience, one should know that. So we don't use it routinely.
Okay. And you are using a linear transducer, I think, for this, a high frequency linear transducer, no? For this evaluation.
Yes. Yes.
Okay. Very nice presentation. We have to move forward. Then we can go back for this discussion during the clinical case presentations. So I'd like to invite Professor Lahan to present your speech about MRI and how it can add the decision-making process in urethral reconstruction. Professor Lahan.
First of all, I would like to thank ICS, especially Professor D'Ancona and Riseto, for the invitation and kindly introduction. It's a pleasure to be here. Now we are going to see how MRI can add in this setting. I have no disclosure. In the next 10 minutes, I will highlight MR advantages in male urethral strictures. I will point some important issues on method technique, which sequences are useful and why, and I will show you some interesting and didactic cases. So as you saw, it's very possible to study urethra and urethral stenosis with retrograde retrography and voiding cystoretrography. It's good for assessing not only anterior but also posterior urethra, but there is radiation exposure, and the big problem is that it does not access beyond the lumen. It's also possible, but not so useful and not so common in practice, the urethra study by CT, cysto-CT, or voiding CT. It's quite difficult to perform, but it's possible. So with this method, you can access lumen, but you need the voiding only images. It's not so usual. We do have ionic radiation exposure in this case, and you do need specialized personnel. And also, as the first method, it's limited to access beyond the lumen. As Professor Niklish told us, ultrasound is a very good method. There is no radiation exposure. It can access soft tissue beyond the lumen, but it do need specialized personnel and the great advantage is that it is a low-cost method. But we are going to see now the advantages of MRI in this setting. There is no radiation exposure. It's good for children. We have an incredible soft tissue contrast, an incredibly superior soft tissue contrast with a high resolution image and multiplanar capability. We can use voiding images. You can perform and use sequences during voiding. It's possible, but it's quite time-consuming. The preparation of the patient, and the exam lasts approximately 30 minutes. And of course, you do need specialized personnel also. So the greatest advantage of MRI over the other methods is superior soft tissue contrasts. Here we see some examples of these exams. And so retrograde uretrography and voiding cystouretrography. This is an example of voiding cystotomography, showing us a focal stricture of an urethra in a female urethra. Here we can see one more example of ultrasound, application of ultrasound in this setting, but Dr. Nikish showed us a lot of videos and images, better images. And here I show all sequences of MRI in this evaluation, in male urethra evaluation. So we have sagittal tissue-weighted image, coronal tissue-weighted image, axial tissue-weighted image. So this multiplanar imaging show us exactly the point of stricture, but you can see not only the stricture, but also the soft tissue beyond the spongial fibrosis, beyond the lumen, not only the lumen. We can also do some curved reformatted image, so you can see all urethra in the same plane, and the lumen itself, and the right position of the stricture. It's good for seeing when you have multiple strictures, and you can clearly see not only the stricture, but also the soft tissue beyond, and the thickness and the fibrotic tissue involving the urethral stenosis. We can use also voiding images. In this is the sagittal plane. We can show all urethra and patients bladder emptying. So in this point, we have the stenosis, and during all images, we see this stricture permanently. Optimal visualization of male urethra requires proper patient preparation and positioning. For this reason, we use saline infusion to promote diuresis, penile sterilization, gel lidocaine injection, and proper penile positioning. We have to position it in the midline, pin it, paying attention not to pull or compress the penis. Glans sulcus is tied using gauze to prevent leakage of the gel, and the dorsiflexed penis is taped against the anterior wall of the abdomen in the midline. So we have to pay attention not to rotate penis along this axis, along its axis. And which sequences and why we use in this MR exam? we use axial T1 weighted image to study all the pelvic to see how the pelvic, not only the bladder and urethra, but we can see the prostatic prostatic bed and also seminal vesicles and other pelvic pathologies also. But we perform multiplanar T2-weighted images. This is very good to see not only the urethral lumen, but also the local of stricture. And we use dynamic urographic image. It's obtaining during rest and mictional effort to see all and mainly posterior urethra during voiding. It's useful. And we use pre and post contrast image. It's good. It's good not only to confirm the stricture, but also to see the fibrotic tissue and be sure that it's fibrotic, that have delayed enhancement during this post contrast image. Let's see some case. We can see here a case of a 40-year-old man with chronic urethritis and cicatricial stricture. We have 2 points of stricture in this case. This is a focal annular stricture, and this is segmental stenosis. So one advantage of MRI is that you can see, you can study multiple stenosis, not only so the liquid that distends the lumen allows you to see not only one stenosis, but all multiple stenosis. It demonstrates not only the stricture itself. Here is the annular stricture, and here is the segmental stricture, but it can see not only the stricture itself, but also the epithelial layer thickening at the site of the stricture. And we know that establishing the location and length of stricture, as well as spongial fibrosis degree, are critical factors for the correct choice of treatment methods. We confirm the stricture as this urethral segment. Don't feel any time during this voiding sequence, and it's important. It's not a static image, it's a dynamic one. So the stricture is always present during all image sets. This is another case of a 60-year-old man with segmental stricture. And again, it demonstrates not only the stenosis itself, but also the epithelial layer thickening at the site of stricture with fibrotic tissue, spongial fibrosis. And in this patient, maybe because of the high bladder, this patient had a past of colorectal surgery, and maybe because of the stricture and high pressure inside the bladder, the fistula, there was a fistula between bladder and rectum that is very nicely shown here in this dynamic image. And the last case, a 71-year-old man with vesico-urethral anastomotic stricture after radical prostatectomy. Here we can see the vesico-urethral anastomotic stenosis shown here in this blue arrow, and it always, in all set of image, this the lumen was distended, and so we show not only the stricture but also the fibrotic tissue beyond the lumen here in spongial fibrosis. And this case was also studied by dynamic voiding MRI, and we didn't see the lumen distension in this point in all images, so confirming the stricture. It was a real stricture. So some take-home messages. MRI is effective, allows accurate study of the length of the lumen, and lumen patency, with great advantage over the other methods, especially in case of multiple stenosis. It provides good evaluation of stricture surroundings, especially spongial fibrosis, thanks to its superior soft tissue contrast and high tissue resolution and a good spatial resolution. And this is where, in my opinion, this is where MRI adds value in the assessment of spongial fibrosis. There is also the possibility of assessing voiding images, voiding retrogram during MRI, and there is no ionic radiation exposure, but it requires very specialized personnel and is somewhat expensive. I'd like to thank you all for your attention.
Thank you, Professor Lahir. Nice presentation also. I'd like to ask you, you presented huge images about dynamic MRI, but I'd like to ask you if it's a routine established among the radiologists to give this kind of images for the urologists, or urologists have to specify in the request what he suspect about that patient, or we have to have a friend radiologist or a radiologist that have a special interest in uroradiology to ask for this examination. What do you think about your practicing routine?
Yes, good question, Professor. It's not routine. It's not routine among MRI department. It's not routine among general radiologists. It's not also common to see abdominal radiologists doing this, performing this exam. It's a very focused exam, so you have to be clear in your request what you do need, and you have to know to whom you are asking this specific and this focused exam. It's not routine beyond us radiologists, where it's quite difficult to perform. You do need a lot of special patient preparation to have good images. It's also difficult because it's time consuming. So in the time you perform one exam, as I showed you, you could perform 2 or 3 regular pelvic examinations. So it's time consuming, and this of course turns the method more expensive and more difficult to see.
Okay, thank you very much about your considerations. Now we move forward to Professor Athanasi Billy's speech. Professor Athanasi prepared it for us, and it's pre-recorded, so we presented it now.
I would like to thank the organizers for inviting me for this meeting. I'm Dr. Villas from the Department of Pathology at the State University of Campinas in Brazil. I would like to recall the histology of the male urethra. In the prostatic urethra, the epithelium is urothelial, and from the membranous urethra through the bulbar urethra to the urethral meatus, the epithelium is stratified or pseudostratified columnar. Here is an image from the penile shaft. On the right, we have here the corpus spongiosum, and on the left, the urethra with this pseudostratified epithelium. The main causes of urethral stenosis are traumatic or inflammatory. The traumatic may be external or iatrogenic, and the inflammatory may be urethritis, and this entity, the lichen sclerosis heterotrophicus, known also as balanitis xerotica obliterans. Here is a traumatic ulceration of the urethral mucosa. You can see in the ulcer, in this acute phase, the necrotic cells, fibrin, inflammatory cells, and here in detail, the necrotic cells, the inflammation, and the fibrin. And according to the evolution of this scar, we have a fibrotic scar. There is a proliferation of fibroblasts. As you can see here, is proliferated fibroblasts. Yet, in more advanced scars, the fibrous tissue gets hyalinized. And this is important here. A very extensive area of hyalinized scar is important because the more hyalinized scar you have, the more stricture you have in the urethra. The penile lichen sclerosis heterotrophicus is a chronic atrophic mucocutaneous lesion. It is considered, albeit controversial, a preneoplastic condition associated with non-HPV variants of squamous cell carcinoma. The lesion may precede, coexist with, or arise after the development of carcinoma. It is suggested that it has an autoimmune etiology. Most frequently involves the glans penis, prepuce, and urethral meatus, but may as well involve the urethra of the shaft. Here we have a typical picture of a lichen sclerosis. The epithelium is atrophic with hyperkeratosis. We have a homogenized collagen band beneath and another band of lymphocytic infiltrate. Here in another picture, the atrophic epithelium, the hyalinized band, and the lymphocytic infiltrate. Over time, there is an increase of the homogenized collagen band, and this is the cause for the stricture of the urethra. The association with carcinoma remains a matter of debate. As you can see here, it varies, the percentage of this association. This is the largest study was based on 522 patients, and only 12 patients had this association, 2.3%. In our files, we had 2 cases of lichen sclerosis associated with squamous cell carcinoma. One of the cases was an incipient squamous cell carcinoma in superficial, as you can see here, very incipient and superficial, but the other one was an invasive squamous cell carcinoma in the corpus spongiosum of the glans. In another picture, it was a differentiated squamous cell carcinoma with formation of abundant keratin.
So, thank you, Professor Atanasi, about your presentation. I'd like to ask you, you told us that most of the urethral strictures are secondary to trauma, iatrogenic, or lichen sclerosis and atrophic. But is there any other primary case for this situation in penile urethra, for instance?
Well, we should not forget there are unknown causes for this structure and some other very rare, for instance, tumors of the urethra. But these are very rare and mostly from the bulbar area of the penile urethra, as an urothelial carcinoma or even a squamous cell carcinoma. I think the other causes are very rare.
Okay, and another question, Professor. Do you think it's feasible to use a freezing biopsy at OR to guide the surgeon? It's usual for you to receive this request in pathology department from surgeons.
Not in our department. It is very rare to receive this kind of specimen. But
Okay.
we can, if I receive, we can say if to find the fibrosis and the hyalinized scar. This is important. As I said, the more hyalinized scar you have, the more stricture is involved.
Okay. Okay. So you have to work as a multi-professional team. They are complicated patients. I think all help is necessary to us. So we have more 30 minutes. I'd like to move forward for clinical case that will be present by our senior resident, Marina Correa Viana, of Department of Urology at the University of Campinas. Marina, please, can you start the first case?
Yes, of course. Good morning. Thank you, everybody, for the invitation. So, male with pain at the cystostomy. On May 2018, he had an accident where his pelvis was crushed by a concrete wall while he was working. He had an S1 level fracture, a bilateral ischiopubic branch fracture. He had palpable bladder, absence of pain or retroradial, absence of spontaneous voiding. He had done multiple failed attempts of urethral catheterization until a cystostomy was done. Then he was referred to our service in 2020, complaining of pain on every cystostomy exchange, recurrent UTI, and the desire of a urethral reconstruction. On the exam, there was nothing further, and here we have the retrograde ureterocystography and the pelvis MRI. On the first image, we can see the previous approach on S1 level, healed fracture of the ischiopubic branch. Here on the retrograde phase, we can see an important stricture at the transition of the bulbar to membranous urethra. On this phase of this exam, contrast was infused on the cystostomy, and it's clear the stricture about 3.8 centimeters between bladder neck and the stricture point. Here we have the MRI, and if Dr. Lahe could explain for us, it would be great.
Yes, Marina, of course. So as we see in these two images, we have T2 weighted image in sagittal plane. There is a cystostomy. If you could point, Marina, it's nice. We have a cystostomy and a balloon inflated inside the bladder. And in the arrow pointed, we have the fibrotic tissue, the scar tissue, exactly in the same point we saw in retrograde uretrography previously. So this scar tissue, this fibrotic tissue, is quite with a moderate volume. Do you have more images, Marina?
Yes.
So here we see the axial images. In the right, we see pointed the fibrotic tissue involving the urethra, not only the membranous portion, but in the apex of prostate also. Do you have more images, Marina? Yes, and this is the amount of scarce fibrotic tissue involving mostly the right side of membranous urethra. So do you have more images, or this there's all, Marina?
This is the last one.
The last one, okay. So the conclusion is that in the point of urethral stenosis, we have a lot of fibrotic tissue, not only spongial fibrosis, but fibrotic tissue in the periphery of the bulbar and membranous portion of urethra, and besides the penile strictures also. I think it's all for this image, Marina.
Okay. Okay, I think we can discuss some points about this case. I think an information that any urologist would to have is the distance between the stumps, the urethral stumps, I think, to decide about reconstruction. And I'd like to ask you to Professor Nitish, you are comfortable to go ahead with a treatment based on this evaluation, this assessment, Professor?
Thank you. It's a very good case. I think in the UK, we probably get about 50 for the whole country of these sort of cases. So they are uncommon for a population of 60 million. I think, I'm not sure the MRI adds additional information to the excellent urethrogram that Marina showed, which shows quite considerable distraction defect. So the approach to surgery would be abdominal, and I don't think the imaging would alter what you would do. You would need to determine what you do as you operate.
Okay. Can you come back to the retrocystography, Marina, please? Professor Carlos, looking at this cystography, combined cystography, how do you approach this patient? Professor D'Ancona?
It's a very difficult case. The first see of this image, we're very surprised, very distant the stumps. But probably, if you perform antegrade flexible cystography, the distance of the stumps should be lower or small distance, because half of the posterior urethra is not visibilized by this exam. I believe you need to perform this study to know how exact length of the stricture.
Okay, so we start with a flexible antegrade cystoscopy to decide the approach, if abdominal or perineal.
I always perform perineal. Many years ago, I performed abdominal, like Turner Warwick, other professor made abdominal, and also take out the pubis to assess anteriorly. But nowadays, we can do by below. If necessary, you can also take some part of the pubis by below. And most of cases, we can assess the apex of the prostate or prostatic urethra.
Okay, so perineal approach based on this evaluation. And about the continence, you are satisfied with you are comfortable with the images presented by Marina and described by Professor Lahan about the sphincter assessment?
Probably the continence will be made by the proximal urethra, bladder neck and proximal urethra. membranous urethra and the sphincter in this region is out. When you perform the urethroplasty, all this tissue you need to remove. But most of cases, the patient can maintain continence.
Okay, we have the images from surgery, Marina, or not?
Yes. So this patient underwent to an end-to-end urethroplasty. We only have the final aspect of the surgery, unfortunately. And the surgery went well. He was discharged at the second post-op, returned to the appointment 1 week later with no complaints beside the urethral catheter and still with the cystostomy. Here is an image. He had a small wound dehiscence. That's the case.
Okay. Professor Nitish, what are routine for postoperative care of this kind of patient? How many days with urethral catheter, just to show us?
Sure, it's a good case. We would typically the patient would go home the next day. I've stopped using drains in perineal surgery for urethral stricture disease because they get minimal bleeding, and if they do, it just tracks around the subcutaneous tissue. We would then perform a pericatheter urethrogram, so adjacent to the current catheter, the urethral catheter, the radiologist would pass a small 6 French catheter and do a retrograde urethrogram to check there is no leak. If there is no leak, then the catheter would come out and the suprapubic catheter would come out if they could void satisfactorily. If, when they get seen back in clinic at 3 months, if they have incontinence, we would review them again, perhaps 6 months, 8 months later, and if they're still incontinent, consider an artificial urinary sphincter.
Okay, nice. Professor Carlos D'Ancona, here in our service, how you conducted postoperative of these patients?
Like Nikish said, we need to perform before take out the catheter to have leakage. Now we have a project to follow the patient performing non-invasive urodynamics and to see the flow and the pressure during the follow-up 3, 6, and 12 months. It's a new project we are studying now. It's non-invasive, and we compare the blood pressure and the flow to see the evaluation of the patient without X-ray, and only this. It's a new project we are.
Okay, very nice. I think we can move to the second case, Marina.
Okay. So here we have a 56-year-old male with the complaint of voiding effort for the past 5 months. This patient complains about taking too long to initiate voiding, about 3 to 5 minutes with much effort and a feeling of incomplete emptying. He denies nocturia, dysuria, and urethral discharge. He already had an endoscopic urethrotomy at 2016 for an idiopathic stricture with no follow-up since that. He already had a postectomy, denies further urethral approach, and urethritis or STD. On the physical exam, we saw a whitish lesion on the pineal glands associated with urethral meatus stenosis.
Oh. Okay. Professor Nitish, about this examination, what are hypotheses and how you proceed now?
So to me, this is quite a common case. This is looks like he's had BXO, balanitis erotica obliterans, causing obliteration of his external meatus. I'm always impressed to see that these patients can actually void, because often it's very difficult to see the meatal opening in such patients. I think this is an excellent case where ultrasound scan of the urethra would play an important role. I think it would be very difficult to get imaging by a retrograde urethrogram of the extent of the stricture disease. As you know, with BXO, you can get skip lesions, so it can affect the external meatus, then leave areas of normal urethra and then get further disease downstream. So this patient would have an ultrasound scan of his urethra. He would need to void, and this would show good anatomy of the stricture disease. And if it's a very, very distal disease, which is uncommon but possible, he would have a simple meatotomy. So we would just open this up and place sutures around the end to keep it open. If it showed progressive disease of more than a centimeter or so, then he would have a two-stage buccal mucosa graft substitution urethroplasty. The first stage would involve opening up the distal urethra, excising all the scar tissue, and then placing a buccal mucosa graft. And then at 3 months later, come back and tubularize it to make it look normal again.
Okay, very nice. Marina, do you have more images here?
Yes, so after opening the meatus, this patient done a retrocystography, and we can see an extensive penile structure with posterior and posterior dilation of the urethra. And here on the voiding phase, it is assured that the penile stricture is very extensive.
Professor Carlos, what do you think about distension of this penile stricture? It's acquired from the dilations or related to the ligament?
Related to balanitis erotica or lichen scleroso is a challenge case and very difficult, and you need use only buccal mucosa. You can use other tissue because the tissue in the shaft is also have a disease. So the big question if you perform one stage or two stage procedure. It's very difficult. In my opinion, we can start with one stage procedure, open and put the buccal mucosa in the dorsal, in the dorsal of the urethra, and see what's happened. If you have failure, you proceed two stage and probably take out all this urethra and put, like Nikish said, buccal mucosa, and after second stage, perform a tube. It's very, very challenging case.
Okay, Professor Nikish, we used to heard about two approaches in this situation, but I'd like to ask you about the Cook-Iron approach for a case such this. Do you have experience? What do you mean about?
So yeah, we would typically always do this by a two-stage approach. I think the chance of graft contracture is quite high because the urethral plate will be on a diseased urethral plate. It will be ischemic anyway. So he would need a long graft, so quite a lot of cheek tissue. Reassessment at 3 months, he probably will need additional graft. If we've used both cheeks, we would then typically use underneath the tongue, so sublingual. And only when we're happy that he has a decent urethral plate that is wide, at least 2 to 2.5 centimeters wide across the full length of the urethra, we would then tubularize it. I would also, as we've all explained, it's quite a complex case. I would also talk to him about other alternative options, which could include a suprapubic catheter or a perineal urethrostomy, so creating a hole in the bulbar urethra. So you bypass all this complex disease, and he would sit to void.
Okay.
So I have a question.
Okay, go ahead.
I'd like to ask to Professor Atanasi. You show is very low frequency to have a cancer together lichen scleroso. In this case, you recommend perform a biopsy of the urethra?
Yeah, I think it's a good idea because you may have this transformation. I think I would like to see a biopsy in this case. You may have this transformation in this case. It's very extensive. But as I show you, it's very low, this frequency. But it may be.
Perfect.
I'd like to ask you, Professor Bencona, about the other precautions regarding the lichen sclerosus in the post-operative management of this patient, because it tends to recur.
Yes, the problem is the disease is not stopping. Some related to use some immunomodulator to decrease the system immunomodulator. I don't have experience of this type of treatment in this case.
Professor Nitish, do you have experience with corticoids or something like this?
No, I would agree with Professor D'Ancona. These are difficult patients. They often get a recurrent disease. When we've published our results from the whole of the country, looking at urethral stricture disease, the distal urethra is the most problematic compared to the bulbar urethra. They have high recurrence rates and end up needing multiple surgeries.
Okay. Some people here in Brazil used to prescribe self-dilation performed by the patient. Do you use it in your key?
So it is used. It's used with variable practice. The evidence base is, again, quite variable. What I typically find is that patients either stop doing it or find it uncomfortable or traumatic to do it. And the other problem, in theory, is that you're increasing the scar formation, because essentially what you're doing every time you dilate is causing these radial, serial scars and cuts, as if you're doing surgery and dilatation. So your degree of spongiofibrosis will just get worse and worse and worse. So long-term treatment is not a good option.
I have another question. Another question, Cássio. Appear in the literature a new paper about microbiota. In this lichen sclerosa, a special microbiota different from the other case of stricture. Nikesh, you think I have a special treatment, special antibiotic in this case, different from the other normal stricture? You have some experience with this?
No, that's good. Yeah, no, it's a good point. No, we haven't used it. I think the problem is much more related to ischemia and arthritis, which is what BXO is, balanitis xeritica obliterans. So it's much more of an ischemic picture, a lack of vascular supply, I think.
Yeah.
Okay. Any other questions? I don't have questions here. So we can move ahead for the next case. I think, Marina, do you have the follow-up of this case?
No, he's still waiting for surgery.
Okay.
So for the last case, we have a 31-year-old male with main complaint of urinary retention for 12 hours. The patient refers that had already presented this problem before and for the last 10 years suffered from weak and intermittent stream, incomplete emptying, hesitancy, and the need to strain while urinating. Those symptoms progressively escalated in the last 15 days. He has been submitted to 3 endoscopic urethrotomy and in the past year performed urethral dilation with catheters, smaller diameters each time, with no urological follow-up at the moment. So he had no significant diseases, no STD, no trauma, and had those endoscopic urethrotomy at 2014, 17, and 19. At the physical exam, he had a flat abdomen with palpable painful bladder. And at the ER, the patient underwent 2 bladder catheterization with a hydrophilic wire and urethral dilation with polyurethane catheters, and a 14 French Foley catheter was placed. He was referred to our office then with a urethral cystography was requested. So here we can see no bone deformity on the first image. On the retrograde phase, we can see a 1 centimeter stricture at the bulbar urethra with dilation of posterior and anterior segment. On the voiding phase, we can see the stricture. And on the post-void, there was no residue.
Professor Lahana, any comment to this to this exam? Additional comments?
No, the exam was good for showing us that there is only one point of stricture and is a very short segment, is a focal segment, a focal stricture, and this patient during void we could see all posterior urethra and confirm that there was no other strictures.
Okay.
Can I make a comment?
Yeah,
I think the urethrogram does show it very well. Marina, if you could go back to the very first image, please. I think there is a good example where the variability in performing a urethrogram. On the right there, the penis hasn't been pulled adequately, so there is kinking in the urethra, and that may hide a stricture. In the subsequent images, that has been corrected. So Marina, if you could go to the next image, that image, then it's been corrected. But it's very important when urethrograms are performed that the penis is pulled straight.
Nice observation. And Professor Carlos, how you conduct this case?
Now easy case, because short stricture, you have failure of internal rectotomy, the next step is open. So in this case, I believe ultrasound don't add many information because you have corpus spongiosus stricture or investment fibrosis. So you need cut this urethra and corpus spongiosum and tight again.
Could I ask a question?
Yeah.
If this was a primary case and had not had a urethrotomy before, and you got an ultrasound that showed very marked corpuspongiofibrosis, would that change your decision making?
Yes, I agree with you. We will have, I think, the radiography, the case for diagnosis, ultrasound help in the anterior urethra, and MRI help in posterior urethra. And like some years ago, maybe 1919, when we perform a travel, we go to internet and show the temperature, the weather, where you're located. Nowadays, when you perform a urethral surgery by stenosis, more information you have, more easy your surgery, and you know what you have, and not do decision during the OR.
Okay. Let's move to the surgery, Marina.
So this patient had an end-to-end urethroplasty. Here we can see the ureteroscopy with the stenosis. Here is the beginning of the surgery with the bulbar urethra. On your left, we can see the urethra, which has the disease. And on your right, the urethra is already spatulated. On your left, you can see the beginning of the anastomosis, and in your right, you can see the end of the anastomosis. The surgery was smoothly, and the patient was discharged at the first post-op. A 16 French Foley catheter was kept in place for 9 days, and a broad-spectrum antibiotics was prescribed. He returned to the appointment at the 9th post-op without complaints and with a healed wound, and had the catheter removed.
Okay, we are going to the end of our session. Professor Nitish, you have any comment about how this case was operated, about the treatment?
Yeah, that was a very nice demonstrated case, and I would agree with Professor D'Ancona. This would be a straightforward case. You would see the extent of fibrosis and disease at open surgery. We tend now to do a non-transecting anastomotic urethroplasty. So we tend to do a dorsal urethrotomy and join the vertical line in a horizontal fashion, a bit like the Heinrich Muclics pylotomy, so that you're not transecting the urethra. In theory, this is much quicker, much easier, less blood loss, and also you're not dividing the bulbar urethral arteries, so you get less sexual dysfunction.
Okay, nice observation. Very useful. So we are at the end of our session. We are on time. So I'd like to thank you, all the faculty, for their important contributions for this ISS Live, and taking for you all for watching this video. And we hope you gain a lot. And you can now just join us live in Gartner Town if you wish to discuss the topic further with each other. And you can find the link below in the About section. Please visit the ICS Live page to find about the upcoming, the past events. And for those from Latin America, I remind you that Urology Division of University of Campinas holds its weekly clinical meeting every Wednesday at 7:30 Brazilian time. Have a nice day and stay safe. Thank you, everyone, and goodbye.
Thank you.